Hi, this is Lori Manila. I am lecturing on acute renal failure and chronic kidney disease. This is our last in the series on renal disorders. The nice thing about acute renal is there are several ways to clarify the stage, and that is where the kidney failure or the etiology of kidney failure is, as well as stages as the renal failure is developing and as the patient is attempting to recover renal functions. For chronic, there are different stages and such that you will see, and in your book they identify and look at chronic. And as far as treatment, what systems, or excuse me, what signs and symptoms they are having, how complex they're getting, and how it is taking the toll on the body, whether they are moving closer towards end stage renal or they are staying in chronic. There are about 70 to 80%, you'll read different stats, of folks that are in chronic renal failure who don't even realize it. So let's go forth. Objectives, we're going to compare and contrast acute and chronic renal failure. We're going to look at patients' risk of fluid imbalance, because we know hemostasis with fluid is a big deal, and one of the functions of the kidney, the kidneys that they have, it's a huge one. Collaborate, look at some of the things that patients need, in which we must collaborate with our interdisciplinary team. Especially to reduce the chances of having acute renal or chronic renal failure. Prevent patient injury, apply principles of infection control, evaluate data that determine acute versus chronic kidney disease, and to determine treatment effectiveness. Acute renal failure, anything acute, is a clinical syndrome characterized by rapid response. So in this case, a rapid loss of renal functions with a progressive azotemia. This term means increased BUN and creatinine. It usually develops in hours or days with progressive elevations in BUN, creatinine, and potassium, with or without oliguria. I would say this PowerPoint, frequently I'm going to be reading these slides to you as opposed to these other PowerPoints in this section and others. Most of this PowerPoint within it is going to have a lot of information right on this. So if you look at it and then kind of check out what your book has to say also about acute and chronic. Most commonly, acute renal failure follows severe prolonged hypotension or hypovolemia, which happens frequently in surgery or in traumatic situations, or in exposure to nephrotoxic agents. This is just a little cartoon. We can see the glomerulus. This is at the nephron level. This is kind of difficult to see if you're looking on, and if you have created your PowerPoints in the 3 slides like we do so often to put our notes down, and you change the slides, of course, to black and white. This is going to show more easily. You'll be able to read it. Also, within your chapter on acute kidney and chronic kidney failure, they have a really nice diagram showing via the systems the problems that renal failure causes. And it is on page 1077. And that also is going to show you even more than this diagram shows you. So kind of check it out. Acute renal failure. Some of the ways we divide up acute renal failure are looking at where is the problem at. Is it above the kidneys? Is it below the kidneys? So above the kidneys are pre-renal. These are factors external to the kidneys that cause a decrease in perfusion of the kidneys. Some of the causes: hypovolemia, decreased peripheral vascular resistance, and vascular destructions. These are guys that are people that are going through, for example, surgery, prolonged surgery. Folks that have hypovolemia, some of the examples you'll see in your book include, of course, or problems that cause hypovolemia: dehydration, hemorrhage, GI losses. These could be diarrhea, vomiting, this kind of thing, excessive diuresis, hypoalbumin in the blood, low albumin, burns. Decreased peripheral vascular. This can be caused from anaphylaxis or neurological disorder or injury, and septic shock. Vascular destruction could be from, a problem: decreased vascularity, bilateral renal vein thrombosis, emboli, things like that. Destruction itself from trauma. Pre-renal, then next we're going to go from above the kidney to within the kidney, but pre-renal also can lead to intrarenal. We know prolonged ischemia is going to cause damage. It is said, and it makes a lot of sense, that those are experiencing acute renal from a pre-renal factor can heal better. The kidneys can return to normal functioning better, and that as is if it's not prolonged. If the pre-renal, if that circulation to the kidney is prolonged, then we're going to have intrarenal problems. Okay, and that will be the next step. But in pre-renal, this accounts for 5 to 60% of all cases of acute renal failure. And there's some of the other causes: is direct damage to the renal tissue, prolonged ischemia, nephrotoxins. These are intrarenal function problems. So pre-renal would be like surgery, but then prolonged circulatory decrease is going to cause intra, and then when we get into an intra, and this is, remember, anything acute, the most important is we identify what's going wrong and turn it around before there is long-term defect or permanent damage. So from pre-renal, then we go to intra, something within the kidney that has been damaged, the tissue's already damaged. Nephrotoxins, and these are some of the examples. So the list is long of the things that can cause, that are considered nephrotoxic. Contrast media. We know patients that go for any test that has contrast, certain medications would have to be held, such as a patient who's diabetic and on metformin. Metformin would have to be held a couple days before, a couple after, because metformin itself is a nephrotoxic drug, and with the combination of contrast media could be a big problem. Other nephrotoxins, could be, that goes on and on. Patients that are trauma, and have breakdown of skeletal muscle tissue. We know that all tissue goes through the kidney tubules. The tubules, they collect all that sloughed off, or they don't collect it, but all that sloughed off tissue goes through and can clog the tubules, causing death, and the tissues to break down itself within those tubules. Hemoglobin, myoglobin do break down. I was just saying that, and block the tubules, and these cause renal vasoconstriction. Also, primary renal diseases such as acute glomerulonephritis and systemic lupus can also cause acute renal failure. Acute renal failure, some of the subjective symptoms, we see nausea, loss of appetite, headache, lethargy, and tingling in the extremities due to toxins being increased, their uremia is developing. The kidneys cannot get rid of it. In acute renal failure, so first of all, we look at, and going back to the pre-renal and intrarenal causes of acute renal, the third cause of acute renal could be a post-renal effect, like an obstructive process, like a stone, like BPH, and I'll mention this again, benign prostatic hypertrophy, something that is blocking the abilities of the body to get rid of the urine. So pre, intra, and post, and now we're getting into, they are the causes, and now we're getting into the acute renal itself and signs and symptoms. So within the acute renal itself, there are different stages or phases. Many times you'll see these stages look differently. Sometimes you'll just see the oliguric, the diuresis, and the recovery stages. The initiation stage, which you'll sometimes see mentioned, is the injury itself or the problems itself that started off this acute renal failure to start. But most time we see the folks enter treatment in the oliguric phase. When folks enter in treatment into the oliguric phase, it's because they have decreased urination and these signs and symptoms. Most folks do not just come to the hospital. They don't recognize symptoms before this state unless it's been a trauma, and during trauma we see kidneys have been damaged. So in this oliguric phase, it is simply that. If you think of oliguria, what that is it is a decreased urination. And you're going to see this decrease in urination, these amounts, differently in certain areas, in certain sources. In your text, in edition 10, it names 400, less than 400 cc's a day is called oliguria. So in the oliguric state, we're seeing less than 400 cc's. We see these symptoms: vomiting, we can see disorientation, edema, increased potassium, decreased sodium, increased BUN and creatinine. And going back to sodium, you're going to see sodium is mentioned. It can be low, it can be high, it can be normal in acute and chronic renal failure. There is no hard and fast rule. But we see increased potassium, increased BUN and creatinine, acidosis. We can see uremic breath, and this is when the body is not breaking down and getting rid of toxins. We see an overload of fluids here, so we can see signs and symptoms of congestive heart failure and pulmonary edema, high blood pressure, a sudden drop in urinary output, on up to convulsions and coma and changes in the bowels. Oliguric, or the oliguric state, usually occurs within 1 to 7 days of the injury to the kidneys. If the cause of the kidney disease is ischemia, the oliguria often will occur more quickly or within 24 hours. That's why that range 1 to 7. And in contrast to that, your book talks about nephrotoxic drugs. If they're involved, the delay can be up to that max, that 7 days before they note it. This phase lasts about 10 to 14 days, but can last months. It is said, and I read this, I believe, in your book, that the longer this phase lasts, the poorer the prognosis for complete recovery. The next phase in acute renal failure is the diuretic phase. We see an increase of urinary output here, that's the UOP here, a gradual decline in the BUN and creatinine. We'll see decreased potassium, because now we're seeing a ton of urinary output. There's a big there is a big risk, a large risk, huge, of becoming dehydrated. So everything, we're seeing a lot more output, but the kidneys themselves are not able to concentrate the urine, so they're letting everything out, at this point. We're seeing low, perhaps sodium, tachycardia, and we're starting to see an improvement in the level of consciousness. During the diuretic stage, the daily urinary output is around 1 to 3 liters, but it can go up to 5 liters or more. And as I said, the kidneys cannot yet fully function, so we see a lot more urinary output. They're not able to concentrate the urine. They're trying to get rid of the high urea at this time. And in this phase, the kidneys have recovered their ability to excrete waste, but not, as I said several times here, to concentrate the urine yet. Hypovolemia and hypotension often occur from the massive amount of fluid loss. Patients who are seen in a longer state of the oliguric phase will have a greater diuresis as the kidney function tries to return. So we're monitoring the patients very closely right now for hyponatremia, hypokalemia, and dehydration. And this phase may last 1 to 3 weeks, and near the end of this phase, the patient's acid-base, electrolyte, and waste products, where the BUN and creatinine values starting to stabilize. In mentioning some of the causes of acute renal failure, we see acute tubular necrosis here. I mentioned this as part of the intrarenal breakdown, and acute tubular necrosis is a type of intrarenal acute renal failure. It's caused by ischemia, nephrotoxins, or pigments. And ischemia nephrotoxic ATN, or acute tubular necrosis, is responsible, and you can see this on this slide, for 90% of intrarenal ARF cases. Post-renal causes of acute renal failure involve mechanical obstruction of urinary outflow, and those cases are only 5%. During that ATN, nephrotoxins destroy tubular cells, both direct and indirect. With ATN, we may see rhabdomyolysis caused by release of excess myoglobin from injured skeletal muscles. And we see rhabdomyolysis in several different situations with acute. You can see this in the massive breakdown of the skeletal muscles, as it's saying here, during trauma. This can also happen with folks in acute renal failure related to, let's say, military guys who haven't practiced PT as much as they needed to. They're up for their test and they run the mile on a very hot day. They haven't been working up to it. We also see folks, we call them weekend warriors, who are really not up to, high run, haven't been practicing, and their kidneys can't take that. So back to the slide, myoglobin is a protein that acts as the oxygen reservoir for more muscle fibers, and there's some of your causes there. Okay, so kind of putting it together on this slide, pre-renal and post-renal acute renal failure resolve quickly with correction of the cause. Intrarenal, this is when, like an example, ATN, acute tubular necrosis, the kidneys are already damaged, has a prolonged course. They've already have damage. So clinically, acute renal failure progresses through, and like I said, sometimes you see 3, sometimes you see 4 phases. You don't always see the initiating phase. The person might enter treatment at oliguric unless they've had a trauma and they've been in a big accident. You see them in the ER in the initiating stage. Initiating oliguric, diuretic, and recovery. And even after recovery, then, there are a lot of folks who don't go to a complete recovery, who maybe might have to stay on dialysis, or those folks who go into a chronic renal failure and don't totally resolve. Okay. Another way to put these phases, the initiating phase could be called the onset phase. Begins with the causative event and continues until oliguric sets in. It usually lasts hours to days. The oliguric, which we mentioned, and let's mention this again, it's the most common initial manifestation of acute renal with the reduction of the glomerular filtration rate. It is less than 400 milliliters of urine in 24 hours that does not respond to a fluid challenge or diuretics. So let's talk about that. Many times, to prove a patient is in acute renal failure, what they will do is try to push the kidneys to function. So you will see orders for a fluid challenge, a bolus of fluid to be given to the patient to see if we can get them to urinate. And we may give also a IV push of, for instance, furosemide, which is Lasix, to see if we can get them to urinate. Oliguric state, and we said this earlier, usually happens within 1 to 7 days. We sometimes see, depending on the case, remember we said we sometimes see in little as 1 or 7 days, and this can last for a couple weeks. We see that increasing BUN, creatinine, high potassium. We may see high phosphate and magnesium, and a low also calcium. There's those manifestations. We talked about these on those slides. The back, we're now reinforcing and maybe adding a few additional points. We see that decreased urinary output, fluid and light abnormalities, uremia, metabolic acidosis. Now you will talk about acidosis and alkalosis you're going to talk about that more in MedSurg 3. Urinary excretion of sodium may increase potassium access and normal ability of the kidneys to excrete 80 to 90% of potassium is impaired. The kidneys are the main system to get rid of excess potassium. Okay. Hematological disorders, severe hematological disorders are seen in acute renal failure. We see anemia. We see platelet abnormalities. So we watch in bleeding with these patients and decrease red blood cells. Calcium and phosphate excess, low serum calcium. When hypocalcemia occurs, the parathyroid gland secretes parathyroid hormone. This stimulates bone demineralization, thereby releasing calcium from the bones. We have to be very careful, these patients going through acute as well as chronic, on safety and falling. These patients are at risk of breaking bones. They're also at risk of bleeding. We see changes in the RBCs and platelets. We know, in thinking back to anatomy and physiology, to absorb calcium from the GI tract, activated vitamin D must be present, and only functioning kidneys can activate vitamin D, allowing absorption. So continue to pull your anatomy and physiology with you. In this oliguric phase, we know that waste products are accumulating, everything's increasing. The best indicator of renal failure is the creatinine level, as it is not changed by other factors. We know that BUN levels are also looked at, but BUN levels are influenced by age of the patient, other conditions, steroids, temperature, and so on. Neurological disorders start to happen in acute renal failure because the nitrogenous waste. This nitrogen is from protein, the nitrogen in protein that we take in, and this accumulates and can accumulate in the brain, and we're going to see decrease and difficulty in concentrating, and this can escalate into seizure, stupor, and coma, and eventually all body systems are involved in acute uremic syndrome. So remember, I said to you we can think of 4 phases, and we can think of 3. In 4 phases or stages with acute renal, we're counting the initiating stage, which is whatever caused it. Initiating oliguric diuretic recovery. If we count it in 3, we say oliguric diuresis recovery, because many times patient is not seen at that initiation of stage. It's not till longer. So from oliguric, now we go at too much is being let go of the body. Diuretic begins with a gradual increase in daily urinary output. An onset within 2 to 6 weeks after the oliguric stage, and this varies. Nephrons are not fully functional. We talked about this, so they're not able to concentrate, so we can see massive fluid loss and hypovolemia and hypertension. So now we're worried about too much, but the body is trying to right itself. Uremia may still be severe. We're still watching that serum creatinine and BUN. But you are at this stage more monitoring for low potassium, low sodium, and dehydration. And this phase can last for several weeks. At the end of this phase, the patient's starting to normalize, and normal renal tubule function will be reestablished, or we're hoping for that. In the recovery phase now, this begins when the GFR increases, allowing BUN and serum creatinine levels to decrease. Outcome is influenced by patients' overall health and number and type of complications. Age is a factor. The older adults are less likely to recover. Full kidney function and complete recovery, if it is to happen, may take 12 months or longer. Diagnostic studies, and this is just kind of bringing it together. In most of my PowerPoints, we say some of the most important points over and over again. Pre-renal causes should be considered if there is a history of dehydration, blood loss, or severe heart disease. Intrarenal causes should be considered if patient has been taking nephrotoxic drugs. Postrenal is suggested by history of change in the urinary stream, stones, benign prostatic hypertrophy, or cancer of the bladder or prostate, or some of them. So consider your studies related to what's going on. Diagnostic test, history and physical, always, 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 BUN, creatinine, sodium, potassium, pH, bicarb, hemoglobin, hematocrit, urine studies, ultrasound, KUB. This is a X-ray of the kidneys, ureters, and bladder. It is an abdominal X-ray. It is an X-ray that does not require any kind of pre-testing, any kind of prep. Your book does mention, as told to me by a student, that it makes sense to do some abdominal cleansing out, some, I guess, renal, or not renal, most likely it mentions doing enemas and things like that. But the KUB is a cheaper test that generally you can do quickly, or else we're going to do tests that require prep and are more Sophisticated. The KUB is going to tell us overall what's going on. Okay. Then moving on, abdominal and renal, CAT and MRI are going to tell us more specifics. And these are just some of the specific tests you might see. Retrograde pyelogram is one. Others, urinalysis, and might contain some of these things. CAST are going to show you some of the breakdown of the tubules. You know, there's kidney damage, urine osmolality, gravity, hematuria, pyuria in the urine crystals may be seen in breakdown of post-renal or in post-renal acute renal failure, excuse me. Renal ultrasound is often obtained. It provides information about anatomy and function. Renal scan can help show renal blood flow. CAT scan and MRI identify masses, collection, and vascular abnormalities. And these are just some of the diagnostics tests. We mentioned in the beginning of this we were going to look at collaboration. When we know patients with renal problems, we got to treat, turn it around, identify what's going on before this becomes chronic or further damage to the kidneys, or damage that maybe there's not damage to the kidneys yet, or that maybe they can be recoverable. Fluid restrictions and nutritional therapy, so we're going to need a dietitian. We want to make sure a patient has an adequate amount of protein, but not too much protein to do further damage at this time. Potassium restriction, phosphate restrictions, sodium restrictions, calcium supplements. TPN and enteral nutrition for patient. It is best enteral if the gut is working, because if the gut's working, we want to keep it working. It's more natural. If not TPN, we can be giving them central line feedings, IV feedings. Initiation of dialysis if necessary. This can be a temporary issue to bring them back around, and we may need to stimulate urine with IV fluids, dopamine, diuretics. Medical treatment. Patient may need hemodialysis, peritoneal dialysis, or continuous renal replacement therapy. Treatment of elevated potassium levels. High potassium is one of the most serious complications of acute renal, and it can cause cardiac arrhythmias. It is treated very aggressively. If the gut is working, and that is a stipulation to use number 5, sodium pilostrine sulfonate, this is K-exalate. It is a cation exchange resin. It is administered PO or in a retention enema. This produces a lot of diarrhea, osmotic diarrhea, allowing for evacuation of potassium. This can only be used if the gut is working. It's contraindicated if not. Some of these other things on here, if the potassium is severely high, you might see regular insulin. This is given to temporarily, it's only temporarily moves the potassium to the cell to decrease arrhythmias. You have to be more aggressive. The sodium bicarbonate might be used to correct acidosis. This is just temporary. Calcium gluconate is also temporary. It raises the threshold for cardiac arrhythmia. Patient might have to have temporary dialysis and they might be put a temporary IV in to do dialysis real quickly. Nutritional therapy goal is to provide adequate calories to prevent the body from further breaking down or using the lean tissues in the body for potassium, for a protein need. So we need enough to keep the body going, but not too much to push the kidneys further into decline. Daily intake should be 30 to 35 kilocalories. Protein intake is generally, you can see it here, 1.2 to 1.3 grams per kilogram. It may have to be higher if patient is in a catabolic state. potassium sodium restrictions, and that depends on their levels. Fat emulsions can also be given to provide a good source of non-protein calories. If patient cannot take inadequate oral intake, enteral feeding is preferred, to keep that gut going rather than a TPN. Nursing assessment for acute renal, vital signs, INO, checking the urine for color, specific gravity, glucose, protein, blood, sediment, looking at the patient's general appearance. Are they in overload? Do they have bruises? What's the skin color? If patients on dialysis, checking their site for signs of inflammation and infection. Mental status assessment, and level of consciousness. Check the oral mucosa. Many times the oral mucosa will break down. The body is trying some sort of way to get rid of the toxins that have been building up, the uremia. Lungs should be auscultated for overload. Heart should be listened to related to overload. Check the neck vein for distensions. I think I said that earlier. EKG monitoring for signs of arrhythmias. Some of your diagnoses, you can read through this. Planning, all overall goals are the patient will recover from acute renal failure without any loss of kidney function and maintain a normal fluid and electrolyte balance. Health promotion, prevention of acute renal failure, taking good care of the kidneys, taking care of the diabetes if patient is diabetic, hypertension, caring for diabetes or caring for hypertension, caring for oneself, loss of weight, diet control, controlling nephrotoxic drugs if patient works in an industry, watching chemicals, taking safety steps to protect oneself, preventing prolonged episodes of hypotension and hypovolemia, aggressive diuretic therapy. Infections have to be identified and treated. Monitoring contrast media in the older adult or diabetic patient. Overuse of nephrotoxic drugs such as NSAIDs. ACE inhibitors can also decrease perfusion and pressure and cause hypo or hyperkalemia. All right, pardon me, I had to take a break for that for a minute. All right, so you can read the rest of this. Acute nursing interventions. I'm looking down here to see if there's anything. Don't forget about the managing of fluid and electrolyte imbalances. Watching and getting an acute INO. Daily weights. I'm just reading down here to see. Of course, you're going to monitor the electrolytes imbalances using aseptic technique because these patients are at a high risk of infection. All right, it mentioned some of the respiratory complications. Think about some of your interventions there. Skin care to prevent pressure ulcers. Really good mouth care to prevent stomatitis. They get stomatitis, and this is written here when ammonia, and this is the breakdown, bacterial breakdown of urea in the saliva. All right. Additionally, here you're going to see it's reminding you of psychosocial and financial hardships, and patient may have to be prepared for eventual dialysis and even potentially transplantation if kidneys do not recover. All right, there's your evaluation. Okay, now let's go into chronic kidneys. Now with acute kidneys, there was the two different ways to evaluate where the kidneys were functioning at. With acute, of course, mentioning that again, where is it happening? Because we need to turn this around. Is it pre-renal, pre-renal or is it post-renal, and what stage of the renal failure are they in. Now, when we're talking about chronic renal, it is not as easily defined because there are folks that can live forever in a day with chronic kidney disease. It's something like 70% or 80% of folks, maybe not quite that high, that are in chronic kidney failure and don't even realize what's going on. So here we're looking at progressive irreversible destruction of the nephrons. When we think about kidney disease to begin with, remember those problems, diseases, concerns that cause it. And number one is diabetes. Number two is hypertension. And number three are disorders such as glomerulonephritis, cystic kidney, and so on. The stages of chronic kidney disease, and you're going to see different staging schematics, are defined by the level of kidney disease, with the last being end stage. The kidneys do have a remarkable reserve, up to 80% of GFR, and we know GFR is 125 milliliters a minute, can be lost with few changes noted in functioning of the body. The prognosis and course of chronic renal failure is highly variable, and that's why, it's a little bit harder to diagnose, but basically we're watching on how the body is compensating. This is a little picture. Now it's bigger. I have it small in mine, kind of looking at the plan of care for somebody with chronic renal disease. Clinical manifestations: as renal function deteriorates, all body systems are affected. Some of the clinical manifestations you see as the result of those substances that are increasing in the body. But because it doesn't happen quickly like an acute renal failure, the body is able to compensate, and that also keeps the patient from realizing something is going on. There are something like 26 million American adults that have chronic renal failure, and there's something like 1 million more that are at increased risk of it. This is 1 out of every 9 Americans have chronic kidney disease, and over 500,000 are receiving treatments such as dialysis, transplant, and such for end-stage renal disease. Despite all the things that we can do today, advances in dialysis, those patients who go on to move towards end-stage renal have a high mortality rate. Chronic renal does have many different causes, and the leading, and I said to you, was diabetes, then hypertension, third are the glomerulonephritis, cystic diseases, and other diseases that were mentioned in chapter 35 in your text. Chronic renal failure or chronic kidney disease is much more common than acute. And this is more attributed, look at our population. We're getting older, we're living longer, we are heavier, and we have more diabetes and hypertension. And as I mentioned to you before, a lot of folks do not know that they have renal problems because of the kidneys and how adaptable they are. They sometimes don't find out they have anything going on unless, it's to the point where they have some severe signs and symptoms, and then it's difficult to go back and recover any of the kidney functioning. Subjective symptoms of chronic renal failure are relatively the same as acute. We see low sodium, dry mouth, skin turgor problems, confusion, fluid overload, proteinuria, sugar in the urine. Urine might have some of those large molecules because it's not concentrating, it's becoming more permeable to the large molecules like RBCs, white blood cells, and cast which indicate some of the tissue, epithelial tissue of the tubules are breaking down. Skeletal signs and symptoms as we go on: muscle and bone pain, That bone is actually demineralizing, and they can have fractures, they can have calcifications in different places like the heart muscle and joints, eyes, and brain. The skin might be changing, and they might have a uremic, what we call uremic frost, and the skin is yellow. It might have pallor. They're scratching, and some of these folks dig into their skin, and there are special creams that can be used for that. Thin, brittle nails, and they're very poor nutritional status. Clinical manifestations in the urinary system. In early stages, we see increased urination because the body is starting to have the inability to concentrate urine. And as it worsens, oliguric develops and eventually no urine. And so they might have as little as 40 cc's in 24 hours, and we know that that is not enough to sustain life. Stages of chronic kidney disease, and I'm really not going to ask you too much of this, but just think about it. The glomerular filtration rate, we said a normal is 125, and I have been told at times that that can almost go into half. We might see some of our elderly where the GFR is holding maybe in the 60s or 70s. And they don't always term them chronic, but this is one schematic that you can look at, showing going by the stages by the GFR. And you see when the GFR is going less than 15, they begin to prepare for renal replacement. I attended a conference related to kidneys, and this is several years back, and I also read an article, and they were really touting and saying that dialysis, while it extends life on a short term, it also increases mortality if we start too early. So the push was to, depending on how the body's accepting this and compensating, to not start it until it goes low, that GFR. Okay. Folks that have chronic kidney disease, we see that compared to Caucasians, there are 4 times the amount of African Americans who experience this, 2 times the amount of Native Americans, and Hispanics are about 1.5 times higher risk than Caucasians to have chronic kidney disease. Clinical manifestations, there's some of our metabolic disturbances here. A diabetic who frequently they have chronic renal failure, they might start requiring less insulin before due to the body holding on to the insulin. So you have to be very careful. And like I told you in this lecture online, a lot of these PowerPoints have all the information on it for you. So some I'll read and some I'll have you read as you're going along here. High insulin, though, does stimulate hepatic production of triglycerides. So we find these folks with chronic renal failure and renal problems, they're at risk of MI. They have higher lipids in their system. And this is really important to watch. They have this higher lipid. What happens is this increases atherosclerotic heart disease. Fluid electrolyte balance, we know from talking about acute kidneys, the biggest concern is the potassium. Fatal arrhythmias can occur with potassium levels when they reach 7 to 8. And this potassium increasing results from decreased excretion by the kidneys. Potassium can come from food, dietary supplements, drugs, and IV infusions. Fluid electrolyte imbalances, sodium can be normal or low, so you want to be careful. We know that because of impaired sodium excretion, sodium kind of follows water, so the water will be retained as well. Sodium retention can contribute to edema, hypertension, or CHF, but sodium intake is very individual, and the effects are individual as well. Calcium phosphate, watch these levels. Calcium may be low due to decreased GI absorption. The body moves calcium out of the bones to compensate, thus watch for simultaneous or spontaneous, fractures from injury. You want to be very careful. Folks are at risk in these renal failure, chronic and acute, due to, once they fall, first of all, they can fall due to weakness, decrease consciousness, decrease and increase confusion, and then if they fall, they can really be injured. They can bleed due to decreased platelets or fracture more easily. Here you have normal calcium levels. We're going to watch out for low calcium and tetany. And also look at phosphate. Phosphate is released when hypocalcemia occurs. This is due to decreased excretion. Many folks in chronic renal failure and dialysis patients as well will get phosphate binders because phosphate tends to increase. Magnesium is primarily excreted by the kidneys. High magnesium is usually not a problem, not unless we give them or they're ingesting like milk of magnesia or some of the antacids with magnesium in them. So we got to tell them to be very careful. Acid-base balance. Remember, you're going to be talking about this a lot in MedSurg 3. This results from impaired ability of the kidney to excrete the acid load, primarily ammonia, which is from the breakdown of protein. Hematological system, anemia, decreased production of erythropoietin. Other factors that they have problems with the hematological system, the nutritional deficits, decreased RBC lifespan, they're more fragile. If they're on hemodialysis, there's blood loss in the dialyser. And many also of patients that have renal failure are iron deficient and require iron replacement. Bleeding tendencies I mentioned due to platelets, hemorrhagic tendencies, GI bleeding. Remember, anytime the body is being stressed, there can be GI bleed. All of these hematological problems can be controlled or corrected with regular hemo or peritoneal dialysis. Infection, increased risk for infection due to changes in the white blood cells and a diminished inflammatory response. Cardiovascular changes with chronic renal failure, hypertension. We've talked about many of these things. Some patients also have an increased renal production, renin production. Vascular changes due to, for instance, atherosclerosis, increased triglyceride or lipids. Diabetes is a major risk factor. CHF from hypertrophy. This can lead to a pulmonary edema, peripheral edema, cardiac arrhythmias due to high potassium, and so on. Respiratory system changes. They may have cosmal respirations because of their high acid-base balance, dyspnea from fluid overload, pulmonary edema we discussed, pleurisy. This is all from the overload of fluids. These folks are very prone to respiratory infections as well. GI systems, the big ones here are anorexia, so they're not eating much, vomiting, GI bleeding, and gastritis. Neurological system, we might see fatigue, headache, sleep disturbances, encephalopathy. Musculoskeletal system, fractures we mentioned, vascular and soft tissue calcifications, loss of bone mineralization could cause osteomalacia. In the skin we've discussed, and acute, and we see many of these same problems as well. Itching and scratching, ecchymosis, dry scaly skin. Nutritionally, they're in a decline, so you might see very dry skin. Petechiae from bleeding and platelet problems. Hypothyroidism is a problem, tissue resistant to effects of insulin, reproduction function is affected, and these are just some other problems as well, impotence and so on. Diagnostic studies, I'm looking on here, is there anything different than we did with the acute? Renal biopsy is here. All right, you can read through this. Is about the similar diagnostic studies for both. Collaborative therapy. Patients might receive erythropoietin therapy, and they do as well in dialysis to increase the RBCs, to push the bone marrow to create RBCs. Calcium supplementation, phosphate binders for that excess of phosphate. Hypertensive, antihypertensive therapy, so we're having blood pressure meds, measure to lower the potassium, and we talked about that in acute, so look at some of those, such as the K-exolate if the GI system is working. Going back, the adjustment of drug dosage, anything that is even slightly nephrotoxic, or look at the meds because there is decreased excretion and getting rid of, breaking down filtration. We might see some of these drugs build up in the system, so we're going to have some of these drug dosages decreased. Conservative therapy is attempted first before dialysis. Mortality is better that we start dialysis further down the line. Every effort to reverse any causes of renal failure, of course. Goal is to preserve whatever renal function they have for as long as possible. Drug therapy, and these are previously discussed in acute renal for hyperkalemia, hypertension, renal osteodystrophy due to calcium and phosphate imbalances, because we know these folks are at risk for bone fractures and things like that. Anemia, erythropoietin, and this is given in the form of called Procrit or Epigen. Complications of drug therapy, watching for drug toxicity. We talked about adjusting dosages earlier, drugs of particular concern, and there are thousands and thousands of drugs to watch out for, but DIG is a big one. Antibiotics, pain meds, especially NSAIDs. Nutrition we discussed in acute renal, so you can review that, but include protein restriction. And we use labs to help us with this. Water restrictions, sodium, potassium restriction, phosphate restriction, or some of them. These are some of the assessment devices as well as things we need to do. Of course, weights and vital signs, giving them support, make sure we get a complete history. Some of the diagnosis, we reviewed those in acute renal failure, and they are very similar. Plan, we want to demonstrate knowledge and ability to comply with the regime, participate in decision making. We want them to demonstrate effective coping and continue with their own care for as long as possible. Nursing implementation, help promotion, keep the remaining kidney tissue going for as long as possible, regular checkups, lab work, blood pressure control, sugar within control for diabetes, early detection and treatment of urinary tract infections, acute interventions. I'm looking in here, reporting patients need to report any weight gain greater than 4 pounds, daily blood pressures, strict dietary adherence, understanding of drugs. There's tons of teaching in here, avoiding over-the-counter drugs such as NSAIDs, those magnesium-based laxatives and antacids we talked about. Teach alternative ways of reducing thirst, if they're on a fluid restriction, such as sucking on an ice cube rather than drinking a whole glass, lemons, hard candy, which is sugar-free. Encourage patients and family to share concerns and discuss, and start the talk as needed related to dialysis or potential transplant recipient. Length of time that patient can receive conservative therapy is variable. Remember, they compensate for so long, and some more than others. When conservative therapy is no longer effective, then we start talking about hemodialysis and peritoneal dialysis and transplantation. Kidney transplantation, your book does a great job at looking at this. In the new edition, it goes from 1092 to 1097. I would check that out. There's some great new advances in there, and it really talks a lot about selection of those for transplant. It talks about live versus cadaver transplant, and so on. But if folks are able to have a transplant, of course, a lot of the signs and symptoms they're exhibiting can be reversed with that, which just is amazing. But there aren't enough kidneys, around for these folks. So both cadaver and liver donor transplants, we're on transplant right now, and I told you, look at 1092 to 1097. Your book does really go into some good information, valuable information related to transplantation. I'm not going to ask you a lot of information on transplant. This isn't, if a patient's having transplant, they would have to be in the intensive care unit for a period of time. Smaller hospitals do not do transplants. As far as transplants, just to throw out some stats to you, as far as the list for kidney transplants, more than 100,000 folks are on the list for a transplant, and yet approximately only about 17,000 of them will get a transplant every year, and most folks die while waiting for a transplant. A decreased donor list, excuse me just for a moment. I am back. Okay. So there is, and we've all known there's so many more need than there are donors out there. Your book says the average wait time in the United States for a cadaver kidney usually range from 2 to 5 years. Kidney transplantation is very successful. A 1-year survival rate is over 90% for those with a deceased donor transplant and 95% for a live donor transplant. That's pretty cool. I didn't know it was that high. And there is a place on 1092 that talks to you about recipient selection. I used to always tease, and it was like the men in black who gets these kidneys. And then from time to time you hear something out in the media that says, oh, all the stars get them, but nobody else can get them. But it looks like it's very restrictive. But who knows? The donor kidney, when they do transplant surgery, is placed in the lower abdomen of the cavity, and they don't always have to remove the old kidney, which is kind of interesting. Usually what I'm told is it shrinks up, and there's less chances of problems when they leave it there. I don't recall what that rationale was further. Now, patients too who have transplants, they have to be willing and be able to take care of themselves after and continue these immunosuppressive drugs and such. These folks will always be at risk for infection and cancers with long-term therapy. When we talk about the immune system, and just to throw out to you, cancer, we often think of just infection, but the immune system is a sentry, and it picks up on abnormal cells when we take good care of our body to get rid of cancerous cells. So these patients, anybody who takes these immunosuppressive drugs, is at risk for infections and cancers. Also, maintenance immunosuppression, you can see on this particular PowerPoint, steroids are given. Okay. Side effects of steroids, we know that impaired wound healing, emotional disturbances, osteoporosis, and so on. So we got to watch out for some of those problems. Other drugs, so this is mentioning some of those immunosuppressive drugs, and it's mentioning specific ones that inhibit T and B lymphocytes and T cell depressors. Okay, little picture on removal of a kidney and how they put that kidney in just a little cartoon kind of figure. Lots of care for these folks for kidney transplant. Live donor and patient, remember, need treatment. The live donor themselves has to stay in, or it used to be, for a week and be watched really carefully that their other kidney kind of takes over. We are, for purposes of our slides, we're talking about care for the patient receiving. But they are in the ICU. The first priority is fluid and electrolyte balance, close monitoring, especially for that first 12 to 24 in the ICU. And at first, patients most likely will be putting out large amounts of urine, so you got to watch, that they're not becoming dehydrated. We're watching the lights. The urine in these first 24 hours will be checked hourly. Don't forget, and I mentioned to you that some of these immunosuppressive drugs that are given, rejection is a major problem, and it can be a cause of death. But there is that huge success for those folks who are lucky enough to get a kidney. Now we're going to go on and talk about peritoneal and hemodialysis. And edition 10, and I didn't pull out edition 9 to look at this particular part, but really goes into some of the newer treatment for these patients, including doing their own hemodialysis at home. And I do have a colleague whose husband, unfortunately, I couldn't get it all set up for this particular semester, but he does his own dialysis, and he's been doing it, I think, for the last couple years. I might be wrong, but I think it's for a couple years now. At home, has his own dialysis machine, and he is doing a good job. So peritoneal, what is dialysis? Dialysis uses some of these physical science subjects here of, osmosis, diffusion, ultrafiltration. It is the movement of fluid and molecules across a semi-permeable membrane from one compartment to another. Clinically, it is a technique in which substances move across from the blood through a semi-permeable membrane into a dialysis solution. We call this dialysis solution diacylate, and we use diacylate in hemodialysis and peritoneal dialysis as well. It is used to correct fluid and electrolyte imbalances and to remove waste products in renal failure. It is also used to treat drug overdoses. The main indication to start dialysis is high potassium. There are two broad methods, peritoneal dialysis and hemodialysis, and both of those can be done in different ways. Dialysis is begun when those conservative methods we talked about are not working, and this criteria will vary. One doctor at the University of Pennsylvania, he did a study and he found patient mortality increased if the dialysis started before the GFR was in the 5 to 10 milliliter a minute range. Remember back in the chronic, when I put up that stage, it's on your PowerPoints, it talked about at 15. So, and I mentioned to you there is some criteria, or there is some research articles out there about starting at lower and mortality. General principles, and I said this, it's maybe in different terms, but solutes and water move across a semi-permeable membrane from the blood to the diacylate, or in peritoneal dialysis from the diacylate to the blood in accordance with concentration gradients. So we got the principles, as I mentioned, diffusion, osmosis, and ultrafiltration, and you can read that further on this PowerPoint. PD has been used since '73 as a chronic treatment in the U.S. There were approximately, when I looked this up, and I think I confirmed this maybe a year or two ago, 10 dialysis patients receiving PD as related to hemo, more receive hemo. But in recent years, the use of PD has decreased. This increases and decreases, and it's hard to get a direct number. Um, it was once hoped that hospitalization and complications would be less um, amounts with PD, but this really wasn't realized as they thought. The benefit of PD is at times you'll hear and read the quality of life. The patients get to do this at home and they don't have to go to a hemodialysis unit. Some folks, though, find the peritoneal dialysis to be more restrictive. They want to go to the dialysis center and just have it taken care of. Somebody else is taking care of it. They're nervous. So there are different options here. Peritoneal dialysis, and this is just a little primitive cartoon. You can see this person has a catheter into their abdomen. It's going into the peritoneal area. This takes like 2 weeks for it to, as they call, ripen up enough for that tract so they can use it. In reading in your book, I did read they could use it acutely if they needed to. But most times, if the patient is in dire straits like that, they'll turn to hemo, a temporary hemodialysis in the end. But back to this picture, so you see there is, or I'll describe to you, there is a catheter put into the abdomen that is done surgically, and then we have a bag of diacylate. This is usually anywhere from 1 to 2 to 3 liters in size. The area where we hook up those together is cleansed for a period of time, and you'd have to check your policy. There is also here what you don't see on this picture in a setup, and we'll have those in lab, is you'll have another bag that will be below the abdomen, and there'll be a shutoff valve. While this is running in through the one valve, we'll shut off the other bag so it doesn't just run in and out, because it has to sit to pull out toxins. So there'll be another bag down below with a shut off and the one bag up above, and there'll be 2 clamps. So once this runs in, then we shut that off and we let it sit, and then we will drain it out. So the PD uses the patient's peritoneum and the abdomen as that membrane across which fluids and dissolved substances like lights and urea, glucose, albumin, and other small molecules are exchanged from the blood. Fluid is introduced through a permanent tube in the abdomen, a catheter in the abdomen, and flushed out either every night while the patient sleeps. They can do an automatic with several exchanges during the night and leave the last exchange in the abdomen, or they can do regular exchanges through the day, usually about 4 during the day. So there are several ways to do that. PD is used as an alternative to hemodialysis, though it is less commonly used than hemo. It has comparable risk, but is significantly less costly in most parts of the world, with the primary advantage being here to doing treatment outside of a medical facility. But I did mention real quickly there are some folks now, and I don't know what the criteria for that is or the cost, and that is something I could ask my friend who do hemo at home as well. The hemo that is done, and I'll mention this again, at home is done in smaller amounts and is done on daily rather than 3 times a week. Catheter placement for PD is obtained by inserting a catheter through the anterior abdominal wall. This is done surgically. It is done so that placement can be visualized before the start of PD. It takes 1 to 2 weeks for proper sealing. And like I said, I did read on your in your book that, excuse me, let me go back one, that they can use it acutely too if needed. I wasn't aware of that. Daily catheter care includes the application of an antiseptic solution and a clean dressing, as well as a real thorough examination of the catheter site. This is cleansed I've always been taught sterilely, because one of the things that will discontinue a PD, being able to do PD for patient and having you on hemo, is having peritonitis from an infection of the wound. Dialysis solution and cycles. Solutions are available in 1 to 2 and sometimes larger, like 3-liter plastic bags of the fluid. The fluid has a light electrolyte composition similar to plasma. The solution is warmed, and some folks at home don't warm it, they just have it room temperature. And in the hospital, we used to do warm temperature or warm it, but it depends on your policy. There are warmers. They're not stuck in the microwave or anything like that. Ultrafiltration during dialysis depends on osmotic forces, with glucose being the most effective osmotic agent. So in these dialysis solutions, the electrolytes are similar. They're also a high percentage of glucose in it. This high glucose pulls out the toxins. In peritoneal dialysis cycles, there are 3 phases. The inflow, when we put it in. Before we put it in, we have patient void. We have patient get comfortable in the bed. If they're in the hospital, we would put a sign up to see the nurse, go to the nurse's station before entering. It is best for them to be alone in there, their own body flora. That's why peritoneal dialysis is best if the patient is doing it at home for themselves. They don't have the risk of these other folks, their body flora, which might be causing infection. So you make sure patient's comfortable, the area is cleansed, their catheter cleansed per policy. The fluid is warmed. We have a sign up. We have the door shut. We're going to do inflow first. It usually takes anywhere from 10 to 20 minutes at first. Patients have a low tolerance for this diacylate. It burns a bit until the body gets used to it. The peritoneum is not used to anything in there. So we'll put that in. After the solution has been inflowed, the inflow cap is closed before air enters. And in the second phase at the top, the dwell, and then we have an explanation here. The dwell phase is when diffusion and osmosis occurs, when that fluid is sitting in there and pulling through the peritoneum out the toxins. Duration can last 20 to 30 minutes or 8 or more hours. Dwell time is ordered. Drain time usually takes 15 to 30 minutes and may be facilitated by gently massaging the abdomen or changing positions. So in orders for patient, when patient is to have dialysis, we'd have what kind, peritoneum, hemo, how many times a day they're going to have it or how many times a week. Hemo, if they're going to facility, usually is 3 times a day. If they're at home, is daily, and it may be several short cycles daily. If patient is having peritoneal dialysis, if it's going to be, a daily thing, they might have four different cycles. If they're having it nighttime, how many bags during the night? So we would have that ordered. The inflow is not ordered, how long it will take, that's tolerance of patient. Dwell time would be ordered, how long that fluid needs to stay in there, and drain time is not ordered per time. But really that dwell time is the time in which dialysis, peritoneal dialysis, is taking place. Before you do peritoneal dialysis, I was always taught to weigh your bag, and you weigh it after. You know the fluid when it's going in, it should be nice and clear. When it comes out, it should still be clear, but you will see it yellow, as if uremia or urine color, it comes out, and then we would reweigh that bag as well. 2 types, and now there's even more, but the 2 types we have mentioned here: automatic or automated during the night. So many bags go through and the last bag stays in the abdomen with continuous peritoneal dialysis going on there. Continuous ambulatory peritoneal dialysis. Um, they might have 3 or 4 times per day. Automatic peritoneal dialysis uses that cycle to deliver, and it controls the fill, dwell, and drain, and that cycles 4 or more exchanges per the night. Patient disconnects in the morning and usually leaves the fluid in the abdomen during the day. They can have 1 or 2 manual exchanges during the day, but may be prescribed to ensure, and this may be prescribed to ensure adequate dialysis, not only the 4 at night, but 1 or 2 during the day. If they're having more of the continuous dialysis, they might have 4 during the day and at night rest. New cyclers, they used to be big and now they are much smaller. Continuous peritoneal is that 4 times at least per the day, as I said, and they exchange anywhere from 1, 1.5 to 3 bags of, 4 times a day, and 1.5 to 3 liters, or 1 to 3 liters of fluid per time. Patient instills 2 liters of diacylate from a collapsible plastic bag into the peritoneal cavity. Okay, so it can be anywhere from 1 to 3 liters. Most frequent is the 2-liter bags. Complications, PD, site infection. Most common bacteria written here for you, Staph aureus. If not, treatment may result in abscess formation. This can also cause peritoneal dialysis or peritonitis. Peritonitis can be deadly. This could be a one-time and cancel peritoneal dialysis deal and move into hemo. But patients can die from peritoneal dialysis, high fever, they have chills and so on, loss of consciousness and whatnot. If we feel they have peritonitis, we might be asked to that last bag of peritoneal diacylate after we have finished dialysis, we might be asked to cut the tip or send a culture from that bag. It does result from the contamination of diacylate or tubing, and it can also be from infection around the site. Clinical manifestations might be cloudy peritoneal drainage. GI manifestations, they're uncomfortable, they have a lot of pain, they might have a board-like abdomen, hyperactive bowel sounds. They will do cultures and Gram stains, antibiotics, PO, IV, or into the peritoneum. And 1 or repeated infections, this may have their the discontinuation of their peritoneal dialysis and changing to hemo. Abdominal pain is common at first due to sensitivity, and I mentioned this earlier, of the peritoneal cavity. And then, so at first we start low, and this is also due to the low pH of the diacylate solution. Outflow problems, kink in catheter, patient, if they have a large abdomen, where the omentum might wrap around the catheter. They also might have migration of the catheter out of the pelvic region. Effectiveness, adaptation of PD, advantages. It's usually about 5 to 7 days to educate them if they're going to do it themselves, but it depends on the people and who they have to help. They have more independence. Many folks want to do it and they feel more independent, ease of traveling, they can take these things with them, fewer dietary restrictions. Disadvantages, time consuming. Some folks don't like the idea of that catheter hanging from their abdomen, and peritonitis is definitely that chance of that as a disadvantage. Orders, and I mentioned this before, but it's written out here for you. Type of dialysis, in heme, how many times per week. Nowadays, they also have hemodialysis. They have patients, as I mentioned earlier, and your book goes through it a bit. They can have their own machine at home and do The ones that they use at home do short periods of time, not as, how do I want to say it, powerful exchange of blood at home, so they have less side effects, but it has to be done daily. If they're going to a center, it's usually 3 times a week. We need to know what meds are held before, maybe given after. In PD, how many exchanges, what the solution is, the dwell time, and what type of peritoneal dialysis. Is it automatic? Is it continuous, given during the day, or automatic, given on a machine, several exchanges, or so on. In hemodialysis, and this is a real old picture, this is a little gentleman who is plugged up to hemodialysis, the same physical science techniques are being done. It is osmosis, diffusion, and ultrafiltration. These folks have to have a apparatus called a fistula put into their arm, where a vein and an artery are connected, helping the vein to get used to the large amount of blood going through the artery. This takes a couple weeks to prepare. They can also do a temporary and acute deal, or in emergency, they can put a temporary central line in the jugular vein. It's one issue. They use 2 large needles, 14 to 16 gauge to use them, and 1 pulls from the circulation to the hemodialysis machine. The other needle is used to return it. Let's go on to this next one. And I'll go into more specifics here as we're going on. When hemodialysis came out, now you could see, I think I had with PD, it came out somewhere in the 70s. And you see hemo has been around longer, came out in the Netherlands, came out a few years later in the US. They have to have that vascular access. I started telling you about that. It takes a period of time to develop. Shunts aren't used much anymore. This is when they take an artificial piece and make a U-shape. Can be celastic tube. It can be made out of other substance as well. And they'll graft it together on an artery and vein. There's more of a chance of exsanguination or bleed out with these. So more often they do fistulas. They can also do a graft. Fistulas heal better. And fistula, like I said, is that anastomosis of a vein and an artery. Increased pressure of the artery blood flow through the vein makes the vein dilated, becomes tough, makes it more amenable to repeated venopunctures, and they use 2 large gauges there for that IV access for dialysis. We as nurses, we make sure, we don't do much with it. We don't, we're not accessing it. Definitely dialysis will be after us, but we protect it. And when patient is one of our patients who goes to dialysis and such, we check to make sure they're not bleeding when they come back on the dressing, checking vital signs. Patients many times during dialysis bottom out. So we want to make sure our vital signs are stable, make sure they're not bleeding. We want to place our fingers on the vascular access, and we want to feel a brewery. Or we want to listen for a brewery, and this is turbulent blood flow sound. It's very loud, and that's that artery blood flow going through the vein. The vein becomes more distended then, and we feel for a thrill to make sure it is circulating. Grafts, fistulas have the best patency rates. Grafts, when they take a plastic or other substance and they do that to put that vein and artery together, it takes more time. There's more there's more problems with it. But the synthetic graft can be used for those who really don't have, their blood vessels aren't good enough to put a fistula in there. AV fistula requires 4 to 6 weeks to mature. AV graft, though, excuse me if I said contradictory, requires 2 to 4 weeks to mature. But remember, the AV graft does have more complications, more infection, more risk of bleeding. Temporary, they can do, for instance, internal jugular femoral vein and subclavian, they can do it, but it's not preferred. The interior jugular is a cleaner area. Femoral, we got to be very careful because of where that's at. Also, a lot more blood flow there, so if that's pulled out, we have to apply pressure for a period of time. Dialysers for hemo, they're large plastic cartridge that contains thousands of parallel hollow tubes or fibers, and blood is pumped in these big canisters, and on the outside is the dialysis fluid, which pulls from the blood, the toxins and such, and pulls out the potassium. Ultrafiltration, diffusion, and osmosis occur across the pores of the semi-permeable membrane. It's that canister there with those hollow tubes, and we know in PD it is the peritoneum that is used as that membrane. Procedures: 2 needles are placed into the graft or fistula, the needle close to the fistula, or the red catheter is used to pull blood from the patient, sent to the dialyser with the assistance of the blood pump. The dialyser and blood lines are primed with up to 1,000 cc's of saline to eliminate air. Heparin is added to the blood as it flows into the dialyser to keep blood from clotting, and I'm told it's very minimal. Blood is returned from the dialyser to the patient, brought through the second needle, the blue catheter lumen. The AV fistula does enlarge the veins, so we do see them standing up more. There shouldn't be signs and symptoms on that shunt in the arm, but it does sometimes have a ruddy coloration if that patient is a Caucasian. We want to be careful during dialysis, and some of you might be interested in being dialysis nurses or nephro nurses, but we got to be careful during that time that they don't become dislodged because patient could bleed out, and during the time, because it is a more, what do I want to say, it removes more of the toxins, and so we have to be very careful. Patients frequently have problems with hypertension and such, so we want to know what drugs are going to be held before, so as not to encourage that. Complications: hypertension, we just said, and is due to that more rapid removal of vascular volume. Peritoneal dialysis is much slower, it's not as intensive. Muscle cramps can happen, loss of blood. Hepatitis is not as risky as it used to be, but it still is. Sepsis, there's the disequilibrium syndrome. This is due to rapid fluid changes. They generally, I'm told, they will take the last weight after dialysis and the new dialysis weight, and the difference there is how much fluid they will remove from the patient. Some of these signs and symptoms of disequilibrium: nausea, vomiting, confusion, restlessness, headache, seizures. Treatment is to slow down dialysis if at all possible because they need dialysis. Sometimes, though, due to severity, they have to stop it for now and infuse a hypertonic saline solution or albumin or mannitol. All right, this is the end of our 4th lecture on, and predominantly we talked about acute and chronic renal failure and hemodialysis and peritoneal dialysis. Thanks for your attention, and I will see you soon. Thank you.